Perfect. Thanks, Ollie. So very nice to meet you all in sort of absentia. My name is Harry McMillan, one of the directors of Momenta, as Ollie said, and we'll run you through a bit of background about the service before you get more interesting and relevant stuff from Ollie and Lee. Basically, it's the now snappily called the NHS Type 2 Diabetes Path to Remission Programme, abbreviated to T2DR, which sounds a bit Star Warsy, but it came out of various patient consultation with Diabetes UK. It was better than the previous name, which was a low-calorie diet program, also sometimes referred to as the NHS Soups and Shakes program. So there you go, a full panoply of titles. This is what we'll be covering. I'm meant to get through over the next 55 minutes, so I will crack on. In terms of the background to the service, it's based on a couple of research projects, particularly the DIRECT study and Droplet. DIRECT was a kind of the most groundbreaking study in this area, or the initial groundbreaking study that was done by Universities of Newcastle and Glasgow. And we were fortunate enough to collaborate with Professor Roy Taylor and Alison Barnes, the dietitian on his team, to develop our service. And that's what really showed that remission of type 2 diabetes was possible at large scale through lifestyle intervention and delivered through primary care. So that was the basis of it. And in the DIRECT study, the intervention group at 12 months, almost a quarter of them had lost 15 kilograms or more of their starting body weight, and just under half had achieved remission of their type 2 diabetes, and that was maintained at just over a third at 2 years. And the intervention group had fewer adverse events than the control group. So all of that led to NHS England thinking this was an interesting thing to start to roll out at scale. DIRECT also found it was a very clear and linear link between weight loss and the chances of achieving remission. Not everyone will be able to achieve remission, but the chance of achieving it was very closely linked to weight loss and the amount of weight loss. And remission for this service and for DIRECT is defined as having an HbA1c of less than 48 millimoles per mole off all diabetes medication for 6 months or longer. In terms of the benefits, there are benefits both to patients and practices. To patients, obviously, there's the weight loss. There's also the potential chance of achieving remission. And there's, for most, a reasonably significant reduction in their medications. You'll hear more about that from Ollie in the deprescribing section. Many also get a significant improvement on other comorbidities and improve their healthy living and quality of life. And the entire 12-month program is, including the total diet replacement products, is free for them, funded by NHS England. Practice point of view, obviously, as I said, it's paid for by NHS England, which is helpful. And then also any referrals you make that are eligible for the weight management enhanced service fee can benefit from that £11.50, which won't pay for the full time of making a referral, but will offset it a little bit. And there are also pretty more important but anecdotal benefits to practices, including a reduced demand from people who are successful in the program, mainly as a result of the improvements in their comorbidities and quality of life. And we provide extensive support, as does the ICB, and you'll hear more about that from Ollie, and also Sharon is on the call too, Sharon Rust. So in terms of a little bit of background on the NHS England approach, this was initially piloted, as I mentioned, as the NHS Low Calorie Diet Programme from 2020, and it's seen similar emerging results to DIRECT. So as a result, it's now a national framework service, a bit like the Diabetes Prevention Programme that you are probably very familiar with. And we're one of 5 providers on that. And it also had its name changed, as I mentioned beforehand. Fundamentally, though, it's similar design to DIRECT, and it's jointly commissioned with the ICB. As most of you won't have heard of us, I'm sure, a little bit of background on us. You very kindly selected us as your provider. So we've had the pleasure of working with Sharon and Ollie and Olivia and others for the last few months. And we've been delivering the service since 2020, when we started off as one of the pilot studies in Birmingham and Solihull. And as of 1st of April, we'll be working across 13 ICBs delivering this service, as well as a few other things outside of this service. Most relevantly, we've been working in Bain, Swindon and Wiltshire, and now just started up in Bristol, North Somerset and South Gloucestershire, and have been working in Somerset from the second wave of the pilots and are still working there. Our early outcomes are also in line with direct, so it's a 11 to 13% weight loss depending on demographics and area of different contracts, and which is quite significant, obviously, for a lifestyle-based intervention. There's a pretty positive uptake of a service, so assuming the groundwork that we've done together with your colleagues is successful, that will help you most of your referrals be eligible, and we get a high uptake of eligible referrals onto the service. Now, we officially launch on the 1st of April, but we're having a soft launch from the beginning of March in Dorset, because you've been a bit ahead of the curve compared to some of your peers in other parts of the country, and so that means we can roll it out and accept referrals basically from after this session. If you send us referrals before the 1st of March, we will technically only process them from the 1st of March, but it will probably take you a few days to digest this, get up to speed, and speak to any relevant patients. But you feel free to basically send them to us after this session. So a little bit of background on the program itself. As we said, follows the principles of direct. It's delivered by our coaches who are obviously trained in how to do that. The coaches do not have to be healthcare professionals, a bit like the diabetes prevention program, but we have clinical support in the background, both from a medical director who's an experienced GP and also from a dietitian who's got 30 years of experience and been running total diet replacement services for both diabetes and pre-diabetes for several years. There are 3 phases to the service. Phase 1 is the total diet replacement phase. So that's where your patients will replace all of their meals and snacks, and sadly any alcoholic drinks, with total diet replacement products. So that's soups and shakes and porridges. And that totals 800 to 900 calories a day. So it's a low calorie diet for 3 months. At the end of that, they will go into phase 2, which is called the food reintroduction phase. And true to its name, they will reintroduce one main meal every 2 weeks. So it's a kind of phased down approach of the total diet replacement and phasing in of real food. That's quite structured because that's quite a difficult period for many people as they readjust. Bizarrely, once people have started and got into the 3 months of total diet replacement, that's actually, they often, maybe happy might be a bit of an overstatement. Some are, but some aren't. But they will tolerate that reasonably well. But people get quite nervous when it comes back to reintroducing real food. And then the third phase is the weight maintenance phase. So that continues up until the 12 months of the program, and is the kind of content that you typically find in a diabetes prevention program or tier 2 weight management. So it's about healthy eating, increasing physical activity in line with government guidelines. And then anyone in the third phase is also eligible for a rescue or reset package if they put on 2 kilos over the course of the program. And I can see a few comments coming into the chat. So when I'm talking, Becky will try and respond to those. We'll come on to what the products are in the diet in a minute. But please do keep questions coming in the chat. It's very helpful. In terms of delivery format, so you've got the same program that's a year long with those 3 phases. Your patients will have a choice of either doing it digitally, supported by an app and the coach in the background, or in person in one-to-one clinics, also supported by a coach. The supplier of the T2DR products, we use an organization called Habitual, and they actually set up specifically to support remission in people with type 2 diabetes. They now do various other things as well, but we use their products, as do some of the other suppliers on this service. And we also use their app platform. However, we use our content and our coaches. So it's the same program, it's just delivered in different ways, either in person or digitally, and we use their app and their products. I won't go through the eligibility criteria in huge detail, other than to draw your attention, because you'll get all these slides afterwards and you'll get a recording available afterwards as well. And it's also reiterated on the referral form. But I will draw your attention to a few things which in other areas have historically been the ones that people have taken longest to adjust to, shall we say, and sometimes produced ineligible referrals. And it's helpful, obviously, to try and avoid those up front, because it saves you time, it saves your patient time, and it also saves us coming back to you saying, terribly sorry, this person isn't eligible. So on the first of those is there's an upper age limit of 65. Now, these are all eligibility criteria for the time, well, most of them at the time of referral. So it doesn't matter if they become 66 before they start the program, as long as they are 65 maximum when they are referred. And unfortunately, now we've got into the framework stage. NHS England are very strict on this. And so they really is, when they say 65, if they are 66 in a day, that's unfortunately going to get rejected by NHS England. The other thing is they have to have had a type 2 diagnosis in the last 6 years. So they can't have had type 2 diabetes diagnosed more than 6 years ago. There are some HbA1c limits which won't surprise you. So if they're not on diabetes medication, it needs to be over or 48 or above. If they are on diabetes medication, it's 43 or above. And there's an upper limit of 87 for everyone. If when you've heard Ollie go through the medication adjustment side of things, if at the end of that you are not comfortable referring someone, or you don't think it will be safe to monitor their medications robustly, then it's best not to refer them. And fundamentally, also, if they're on insulin, that's an exclusion criteria. The rest, I think you'd probably expect, given the nature of the service. Go through this in detail, you'll be glad to know, but just to give you an illustration of the kind of topics that we talk about in the different phases. So phase 1, more focused on the behavior change side of things. As you'd expect, we can't talk about healthy eating and physical activity when people are on a total diet replacement regime. Phase 2 is starting to bring in the reintroduced new meals, and phase 3 is what we talked about beforehand around healthy eating and increasing physical activity. We provide a range of different support resources for your patients, quite an extensive range, and they're kind of well produced, nicely formatted, etc. So we think they'll be very well looked after. If they're on the digital service, obviously they get the app as well. So to the comment that asked about what the diet is in phase 1, the habitual, your patients will be able to choose the mix of products that they would like out of the following 10. So there's 2 porridges, 5 different shakes, and 3 soups. So there's 10 products in total. 4 of them are vegan. They're all vegetarian, and most of them are, well, they're all free of common allergens, although we obviously advise people to look at the ingredients list for any specific allergies or intolerances that they might have. We provide the patients with voucher codes. They order directly from this site. They get given samples of the products before they make their first order, and we also provide them with a shaker, a little booklet to give them some advice about how to, bit more advice about going on to a TDR diet. They get free next day delivery as long as they order by 1 o'clock, and that covers all the products they need over the 12 weeks, the food introduction as it's gradually kind of tapered out, and also any reset plan, and it's all at no cost. In terms of resources I mentioned, this is just a snapshot of some of them. So just to give you an idea, there's a TDR booklet, there's workbooks, trackers on recipe book, wallet card, pedometer, etc. The digital app is probably what you'd got most of the things you'd expect to see in an app of this kind for this kind of service. It's a reasonably clean and simple look. It seems to be pretty easy to use, which is one of the reasons that we chose the Habitual app. Nice clean lines, and it's also got things like gamification elements around rewards and stuff built in as well. So you're almost done with me, you'll be glad to know, before we move on to Ollie and Lee and Becky. But first, just to go through our relative roles and responsibilities. So yours from primary care and ours as the provider. So obviously there's no service, or there's a service, but there's no one on it if you don't make referrals. So the primary responsibility, or initial responsibility, is for you to send us eligible referrals. And we will get into. We have been working with the ICB to provide various different support for you to generate those referrals. So whether that's patient information leaflets, which we'll get onto in a minute, and a landing page, posters, we've got an animation. Becky and colleagues will provide drop-ins and support events or support meetings and talk more to and we'll basically do everything we can to support you to make your life making eligible referrals as easy as possible. Not saying it's easy, but as easy as possible and least painful. Once you've made the referral, then technically within 5 working days, but our internal target is within a couple of working days, we will contact the referral, assuming they're eligible, we'll contact the referral, or we'll let them know that their form needs a bit more information and we've gone back to you, so they're not in limbo. And then we will ask them to book in a time for a initial call, check eligibility or confirm eligibility. There's a couple of questions which we'll need to ask them, which won't come through on the referral form. I would also celebrate like that if I was eligible on my referral form. Then we will book them in for an individual assessment, at which point they will choose whether they want to do, or they'll make their final choice once they've had the opportunity to ask any questions as to whether they want to do the digital or in-person program. If it's digital, we'll help them download the app there and then, if they are happy to do that, or book another time to do it. And if they're in person, if we have a clinic coming out or available for them, we'll let them know that's nearby. Otherwise, we'll say we'll get back in touch with them as soon as we can find a few more patients in the same area to put on a clinic. We don't need as many as we do if we were doing a group program, for example, so we can get started with many fewer, but it's helpful to have at least 4 or so to get going. Then we deliver the program, the 3 phases we've talked about. And during that delivery, we'll also be monitoring your patients from a safety point of view. So not just attendance and weight loss, but also blood glucose for everyone, and blood pressure for those on blood pressure medications, or medications that impact blood pressure at the outset. If their measurements are outside of certain thresholds specified by NHS England's expert reference group, then we will contact you either as a notification, or if they're out significantly beyond the thresholds, we will send you a more urgent message that would suggest a medication review swiftly. Or if it's a notification, it's just for you to be aware, and you might want to schedule a medication review at a point in the future if they continue to remain outside those thresholds. So for your sort of understanding, the initial sessions are weekly, the first 4 sessions, and then it moves to fortnightly. So they're partly weekly for the first 4 because that's when we'd expect the biggest changes in blood glucose, particularly to happen, and so that's when it's most likely that there could be any issues starting to appear, and so that's why it's important for us to measure that frequently. And the requirement for communication is checked by our GP medical director before we send it out, so we're not bothering you unnecessarily with communication. Over the course of the program, there are two additional requirements for you in primary care. One is to do a repeat HbA1c at 6 and 12 months. So this is the mechanism by which NHS England will be able to tell, and you'll be able to tell, and your patients will be able to tell if they have achieved remission or not of their type 2 diabetes. We don't do that from our side. And in fact, the specification is very clear that we should not do that on our side. Then the second aspect is that if we send you a notification at the outside of the threshold, then please we'll be able to do a timely medication review so that you can make sure that they don't suffer any adverse events. Right. So in terms of identifying patients, there are three main ways of doing this. One is through a search and then invitation route. So many of you will be familiar with this from the DPP, and Lee will take you through the searches a bit later on. But fundamentally, do a search of the register, screen the search results, because some eligibility criteria are not very easily searchable, and then send the eligible patients or likely eligible patients an invite, either with a text message or messaging service. And we provide you with electronic patient information leaflets and also a link to a patient information landing page, which then tells them a bit more about the service. And it means that only those people who have read it, understood it, and are interested by it will come back to you for a referral. So that's the kind of most efficient way of doing things. However, many of you just be seeing patients on a regular basis in usual care, either when they're diagnosed with type 2 diabetes or possibly when they're in for a medication review or an annual review of some other kind. Occasionally, patients will hear about it from friends or others and ask to be referred. So that's the other default approach. And thirdly, some of you might be interested in running an event at your practice or maybe at PCN level, so we can support with that. It's not. It's particularly useful if you want to, either you're really passionate about this area and you think that your patients will respond better to an in-person discussion about it, or if you're trying to engage with a particularly hard to engage group or groups and either doing it in the practice or potentially with a community partner, then we can support with that. That's not for the faint-hearted. It takes more effort and work, but we've done it in quite a few places and supported it, so we know some of the things that help make it more likely to be successful and a better use of your time. But fundamentally, usual care is the time when it's probably most relevant to your patients because they're thinking about their type 2 diabetes, and the search and invitation is the most efficient route. Then in terms of patient information, we have, as I mentioned, a landing page. So like this, I'm sorry, it's on a wide screen, and you've got the bit at the bottom, which I can't get rid of, but fundamentally it tells people a bit more about the program. They can download a leaflet. It goes through what the program is, shares some case studies, eligibility criteria, and etc. Then we also have a bit more detail on case studies, many more case studies. In fact, the flyer I mentioned, patient information leaflet, which is a 2-page A4, so you can print it locally if you wish, or it's easy for them to print at home if they get sent it electronically. And then there's also a practice poster, which you can print and put up in the practice, which just highlights the existence of the service. There's an animation, which you'll get the link in the video, in the slides. Right, and at that point, it is now over to Ollie.
Great, thanks very much, Harry. So I'm just going to talk to you a bit about the de-prescribing element, because this part, it does sit within us, our responsibility within primary care. So it's really important we understand this process. So if we just go to the next slide. So basically, this program is based on evidence that was collated from the direct study, which was prior to that was informed by the counterbalance study. And just to sort of highlight what it showed is, if you look on the graph on the left, what we saw is that when people started this program, we started to see a reduction in their blood glucose. So quite early on actually, and within the first week even, you saw quite a significant drop in the blood glucose. And so it's obviously therefore important that we do make these adjustments right at the start of this program, not further down the line. And then also just the impact it has on the blood pressure. So if you look at the graph on the right, what we're seeing is actually, again, quite a significant drop quite early on. So the systolic blood pressure dropping by on average, probably by about 20 millimeters of mercury, and then the diastolic by about 10. So we just have to be really mindful that if we are doing this study, that we're going to see those drops. And the reason for that, for the blood pressure, there's probably sort of multifactorial, but one aspect is that actually these meal replacements actually do have quite low sodium levels, so that might be one explanation. But also what we do find in this program is that there is quite significant weight loss, so people end up having about 10 to 15 kilogram weight loss towards the end of the study. So with that, you would expect that the blood pressure drop would be expected. So what the counterbalance in the direct study did, they pretty much stopped all blood pressure medication and all glucose lowering medication. We're being a bit more conservative with this program, in the fact that we are aiming to stop pretty much all glucose lowering medication, but not necessarily the blood pressure medication. But we do have to be mindful of it. But what I'm going to do is, in the later slides, is talk you through those changes. So if we've got any more information. So it's really just to highlight as well that this is our responsibility. We have to make those decisions before we do the referral. So if we go on to the next slide. So we're going to start off with the glucose lowering agents. So just before I do that, just to highlight the three things that we should be considering when we're deprescribing is, one is glucose lowering agents, the second is blood pressure lowering agents, and the other one is sort of the other medication that might be affected by weight changes. And then we'll come into that in a second. So with regard to the glucose lowering agents, we've got this sort of flow chart here, which sort of categorizes it with how many agents they're actually on when you do the referral. So the ones on 0 agents, obviously you don't have to do any deprescribing, that's fantastic, but you still have to fill out the form, so the medication adjustment form. And then those who are on 1 to 2 agents, we recommend stopping both agents, and then you counsel them about what the potential impact will be, and then fill out the form, and then we send those forms off to the provider, so Momenta, and then we also provide the form to the patients as well. And then if the patients are on 3 or more agents, we recommend stopping 2 or more agents, just remaining on 1 sort of base agent. So most likely that will be metformin, but there will be some patients who it's contraindicated, or if they're potentially not tolerating it, and then you're probably left with probably a sulfonylurea SGLT2 inhibitor. Not sulfonylurea. So they might be on a sort of a DPP4 inhibitor, for instance, or even maybe a GLP-1. And then the patients that the groups of medication that we don't want them to be on are the sulfonylureas, SGLT2 inhibitors, and then meglitinides as well. But we'll come on to that. So just to clarify, if they're on 3 or more agents, you stop all but one of their baseline agent, and then you refer them on. And again, you make sure you counsel them about what the impact that might be, fill out the form, and then send the form off to the referral, and then you hand the other form to the patient. And then just a reminder as well, if anyone who's on insulin, this program is not for them. So they're excluded from this program. With this, we just need to make sure that we've counseled them, and then the other thing is, what's really important in counselling them is making sure that they don't stop it straight away. They only stop it once on the day 1 of them starting the program. So just make sure that they don't go away thinking, okay, right, now's the time to do it. It's not until Momenta contact them and advise them and when to do so. So just a little bit about the ones that are safe and not safe to be continuing. Essentially, the sulfonylureas and the meglitinides. The meglitinides you're probably not that familiar with because we don't really tend to use them, but ultimately these 2 groups of patients, these 2 groups of medication, they can cause hypoglycemia, and obviously when we're seeing the drop in the weight, we're probably seeing that the insulin resistance is dropping, and actually they are therefore at higher risk. So really important to make sure that they're off those medication. The SGLT2 inhibitors, so with this low calorie diet, it is low carb diet as well, and so potentially there is a sort of a theoretical risk that they could develop ketoacidosis. So again, we need to make sure that they're off the SGLT2 inhibitors. We've got the GLP-1 analogs as a potential one that we shouldn't be prescribing. It is safe to be prescribing, but I think it's maybe just an opportunity because of the issues we've had around GLP-1s, the cost, but also the availability. This might be a fantastic opportunity to get those patients off or to deprescribe that medication, particularly as well if they're not hitting the sort of the nice guidance where we're expecting that HbA1c drop and weight loss drop well after they started. So take that opportunity if it comes. Okay, if we go on to the next. So really, this is just a reminder. The bottom is just a reminder, not the SUs, not the biglitinides, not the SGLT2 inhibitors. And you need to stop them. And anyone who's on insulin, they're not eligible. Momenta will be keeping an eye on things, and they will flag it up if the patient's blood glucose is over 15. And then we'll be looking out. We'll be doing the HbA1c check at 6 and 12 months, and we can address that if that's going up. So the second group of medications is the blood pressure lowering agents. So essentially, if the blood pressure is elevated, so it's over the target systolic of 140 or the diastolic of 90, then we don't change the medication. We continue as they are. We do counsel them though that, like I said, the blood pressure might drop a little bit. So just to be mindful of any postural symptoms, and if that's the case, then they should let us know. If their blood pressure is less than 140 or over 90, so they're well controlled, then we can consider stopping their blood pressure medication. And then again, we do the counselling, advise them about symptoms. I think it's really important that we monitor those patients who, whether we're stopping them or not, because we might see some fluctuation of their blood pressure. This is a fantastic opportunity with if PCNs or practices are using digital monitoring, such as the Viso app. If you get them onto that, then that's a great, easy way for them to do so. But it's just really important that you counsel them that they do keep an eye on their blood pressure. If they have to come in to have that done, then they can do so. But also they can sign up for the app if they're not already done so. So we'll talk a bit about what to do about their medication. So I suppose with blood pressure medication, I'm sure you're all familiar that actually blood pressure medication is no longer just for blood pressure. It's actually, we use it for a lot of other things as well. So there's some tablets that actually there's other benefits that they're getting from. So for instance, if they are an ACE inhibitor, they also have sort of kidney disease, such as they have persistently high protein in their urine, or they have a CKD, in which case they actually might benefit from continuing with an ACE inhibitor or an ARB. If they have angina, for instance, they might benefit from being on a beta blocker or calcium channel blocker. Heart failure, multiple drugs that they benefit from. BPH, a calcium channel blocker an alpha blocker, and then the migraines as well, beta blockers as well. So I think we're really just highlighting is that actually a lot of these tablets do have other benefits, and actually what we're really making sure that is don't just stop tablets that they're getting added benefits from. If it's solely for blood pressure, then it would be suitable to consider stopping, provided they're well controlled. And the order to do it is relatively intuitive. It's basically you go in the reverse order of what NICE suggests with prescribing. So when you're deprescribing, you basically start with the tablet they started most recently. So for instance, the spironolactone alpha blockers and beta blockers are right at the end of the sort of the stepwise approach. So you stop them first, then you get down to the calcium channel blockers and the thiazide diuretics, and then you finally get down to the ACE inhibitors, ARBs. So that's hopefully relatively simple to sort of process to follow. Okay. So what happens once they started the program? What happens if they suddenly start having some high blood pressure readings? Well, obviously we would just advise them to do what we would normally do. So if the blood pressure starts to go up, then we have to then think about stepping up the blood pressure medication as you would normally. So you just go back up the ladder, and if the blood pressure is too low, so I think it's really important that we then just go back to the process again, and you think, okay, well, maybe we need to deprescribe further because obviously we're seeing some fluctuation there. Really important, again, just to keep on reiterating, keep an eye on your blood pressure, and also just to make sure your fluid intake is up. I think particularly in that first week or two or first few weeks, that's when you see a bit more of the fluctuation. That's when they should really be keeping a close eye on things, keeping their fluid intake up, and just informing us if they're having any sort of postural symptoms. So, so I think it's really just important as well, just to highlight there are other tablets that can be affected, or medications, and these are really the ones that get affected by adjustments or fluctuations in body weight and also dietary intake. So we have the sort of creatinine clearance, which we use weight to work out, and that sort of guides us to, for instance, like DOACs, you're probably most familiar with. Then that helps us to identify or work out what the most appropriate dosage is, and there is a list of other potential medications you should be considering. So I suppose when you're doing the de-prescribing, just think initially, well, is there anything here that potentially we use the creatinine clearance to work out the dose, or what could be affected by the weight? And if there is, then I suppose then think about, okay, well, can I safely adjust this? And is this something I'm comfortable doing? If you feel actually this is not safe to do, they have to continue with this, and actually it's going to be unsafe by us adjusting it, then maybe this patient is not suitable for this program. But obviously you can always liaise with the specialist, whoever started the medication, if you feel that this patient's really would benefit from it, or if they really pushing for wanting to do it, or you can always liaise with us as well, and we can consider what the options are. So if we go to the next slide, it's obviously not an exhaustive slide, but it's sort of an example of things that you might come across. So as I said, you've got the DOACs, warfarin, digoxin. Those are probably the ones you're more familiar with, and then you have other ones which maybe you're less familiar with and might be started by secondary care, the infliximabs and other such things. So I suppose you use your sort of your own judgment here as to whether is this a safe option or not. But hopefully a lot of these patients won't be on a lot of these tablets, and actually you don't have to consider, but it's just really important that you're aware of this. So that's it, actually, I think, from my side of things. Obviously we can pick up any other questions as we're going along. Back to you then, Harry.
Great. So it's back to move for the next slide. So we're going to focus on our referral support now. So exactly what and where to find the resources to find your patients. And Lee is going to go through in a little bit more detail. So as we've mentioned, the first step is to identify your patients, and that's either through the search that we'll cover in a minute. Looking at usual care, and we do have a pop-up that will run in the background. So the pop-up will come up and suggest that the patient may be eligible for the programme and give you the option to refer the patient there and then. And the bespoke option, as Harry mentioned, is something that we can support with for larger groups of patients. Step 2, we do recommend allowing around 15 minutes to do the referral and the appointment. So that includes being able to make the medication changes and making sure the patient is clear on those medication changes as well. After the appointment, it's so important as well that the patient leaves knowing what those medication changes are. So we do advise that they have a copy in writing of the medication adjustment form that you'll be providing to us as well as the patient. And finally, sending it off to our team. As I say, we need all the information, including the medication changes as well as the patient. So once we get that, we will then confirm all the details and let you know whether the patient is eligible and being processed, or if we're missing any information. So I think at this point we're going to stop sharing. And Lee, are you able to take over to show a short demo of where the searches and referral forms can be found?
Yeah, hopefully
Great.
You can see my screen there.
Yes.
Excellent. You can hear me as well. That's good. I couldn't remember. I can't see if my mic's on mute because it's just moved into a different screen. So I'm doing really well for an IT tech. I'm doing really well with Teams today. So it's been one of those days. So I'm going to show you both the stuff that I've built in the demo environment, and also that I've moved it across into the live environment. So I'll show you some of the things in live as well. But anything I'm showing you will be showing you in a synthetic patient, so it's not a real person. And some of the demo is a little bit ad hoc. Because of the test patient nature, I haven't got any of the criteria in the record for it to automatically launch, but basically what would happen if you went into a record that had that was being prompted for the T2DR, it would basically bring up, if you can get it to launch, this pop-up. So you'd get that in there. And basically at the bottom, you get the option of doing the referral straight away, sending a task to your secretaries or admin team, whoever's going to be doing the referral on your behalf, saying that actually you don't do it at this time, or the patient has actually declined the referral entirely. If you use either of the first two options, it'll code it to say that you've made a referral, and it will also obviously, if you've done the refer now, we'll start the document off, so you can start completing the document as well. So you've got the referral plus the adjustments form at the bottom, all in one place. And it'll also put a note into the journal just to say that you've done that process, so that it's clear when you're looking back through, you can see things quite easily and quite clearly. If it's referral declined, it puts a decline code in and then puts in a message to say that the patient's declined to take us up on the offer, basically. If I click on refer now, it'll come straight through to the window that you'll be most familiar with, hopefully. So hopefully all you need to do is already pre-populated. You just click on right now. If you want to put your name in there, you can put your name in as the sender, and you can fill in the recipient if you so wish. I'm going to click on right now, and it's going to open up in Word and probably on a different screen just to be awkward. Oh no, it's actually put it into the right screen. That's even better for me. So again, everything we can, we've pre-populated. Well, I say we, that's the royal we, because I've nicked this from another area, as you may have already been advised. But we've, rather than reinvent the wheel, we've taken what's already out there and amended it to be a Dorset specific. In the live version, I've taken out, I've just noticed it's still the old version here, so it's it should have all the Dorset links in there, and that paragraph 6 will have been removed because we're doing it in a slightly different way in Dorset, so that paragraph would have been removed. But it's all pre-populated with all the information that it can pick up from the GP record, and then I suspect you've been through this already with. So, thank you, Harry. I'll carry on. So basically, it'll pre-populate everything it can pick up for you on the record. Obviously, I'm going to test patient, so there isn't anything there, so it's coming up as saying no entry recorded, but that's because I'm using a test patient that we've not populated properly. As you scroll down through the criteria, it gives you all the detail. It will give you any medications that are already sort of split it out into two sections. So there'll be a section that says there's no current repeat medication or no current medications. So I've split it into two tables, one for repeats, one for acutes. So that they pick up hopefully straight from the patient record for you as well. And then it's the manual filling in of the bottom section of the medication adjustment form. Again, I'm not going to go through this in any great detail because it's just a Word document that's going to be generated and you've seen plenty of times before. Just for those that aren't aware, if you want to be able to tick those boxes, if you just click on the form protection icon, you can then click on any of those boxes wherever you see them to select them, and then before you save it, you just need to click off the form protection again to be able to save it. But that's teaching granny to suck eggs more than likely. But if you haven't seen it before, that's maybe of use. Once you finish the document, you got to save future editing if you want to come back and edit it before you finalise it, because you're going to do it in 2 tranches. If you've done it and completed, you just save the final version. And it should come back to the patient record for me, he says. And if I look at the journal, you'll see there at the bottom that it's put a note in to say that the patient's been referred to the programme. The recode's been added in there, and there's been a referral made as well at the same time. So you can see the document there. Obviously, it goes into commas and letters as normal as well, and it's all in there. So that's if you're using it as a pop-up to prompt you to do it, rather than I'm going to go and do the preemptive work. Just going to switch over to my test patient GP practice, just to show that we've added it also. So I've asked Ardens to add it to their communications template, so that should be available in the next few days, hopefully. And I've already added it to our quick referrals template, which is the ICB version, which I know some of you use. And if you go to the outside Dorset, I've added in a Mentor section, which is just a straight link straight to the actual document there. So rather than have to wait for the pop-up, you can just go and fill it in automatically straight away for you. If that's how you, if it's a patient you've seen and you wish to just do that referral, it's straight there for you. It won't then code it at the same time because obviously this is just picked up in the background. What I probably should do is put some details in so that it codes it and does the same messaging that we've done for the actual protocol as well. I only just thought of that now as I'm just going through it, so I'll tidy that up in the background, and that'll happen in the same way as a protocol will, just without the question in the first place. So it'll just come through with the same actions, and it should just flow through nicely on that one. And Ollie said that you may be doing it proactively, so rather than doing this as a reactive, you might want to go and find the list of patients. And so the reports that have been created, and bear with me because it's going to take ages for it to load the reporting screen for me. I know it will. Oh no, it's done it straight away. That's unbelievable. So there will be in the Dorset CCG, Dorset System 1 GPs sets of reports. So it'll be in that folder there. And I've put everything, all the reports that have been generated to make this work are under a folder for T2DR to try and keep it nice and simple and straightforward. And then you've got the 2 reports that you'll probably want to use are potentially the ones at the top there that have so the top report in that list there now is those that are eligible but haven't declined in the last 12 months. And the report underneath is just those that are eligible. So regardless of whether they've rejected the application or not, they refused the referral. So you've got those 2 reports there. So those are the 2 that you may want to run as a, again, I won't go into any, I won't actually run that report because obviously it'll show you real patient data and I don't want to start sharing that with a wide audience, but that's just basically where those 2 reports are, unless you've got any other questions for me.
That's great, thanks, Lee. And just to highlight as well, if you can't remember exactly how we found that search, you can always just do a search at the top left, can't you?
Yeah, so you can do search up the top there and search for the name of the report.
T2DR, and then it'll come up.
I think it should find, yeah, so it finds,
there we go.
Actually that's it's not the ones that we're after. So if you do it as the actual type 2, because it's, then you'd find them there.
Great, excellent.
So because I've not named them with the T2DR, and so that it's completely obvious what they are to everybody, it won't find it in the search, but you can search by type 2 and then you'll see them in there, and they should come fairly near the top because they'll be the ones that are asterisked.
Good, excellent. So hopefully you can all find that. And then what about the pop-up? When's the pop-up going to first start appearing on people's screens?
Basically when you tell me to make it available to people.
Okay. All right. So I think what we'll do, we'll get some comms out because I think we'll just make sure everyone's aware that these will come. And I mean, it's still relatively low numbers. I mean, we did a bit of a search and we've got within our PCN 60,000, only about 300 patients or so came up. There's probably, that might be a bit higher, but so it's not going to be every patient's going to get a pop-up, but it'll be useful as you go along to know whether or not this person's eligible.
Yeah, so I'll just wait on your.
Okay.
It'll take me a couple of seconds to make it available. So the day you want it to go, just let me know and I can just make it happen, and it'll be there. The rest of it's already there. So if you want to look through which patients are in your reports, they're already available to you and live across the whole of Dorset. So they're already there. The referral document I've already put in on our quick referrals template, and Ardens are putting it through at the moment. So if you wanted to use it, it's available straight away. Providing you're happy for that to go ahead, obviously. That's available straight away for you now. So if you want to look through it and see what it's like, you can do that. I said in the protocol, I've cheated in the demo. I've taken out the criteria of it being needed to be in there in my demo environment, because otherwise you can't find it in the launcher. So I've snuck it into my launcher here, but it will only show you there if the patient is eligible. So you won't see that. You can't start that protocol off for that patient if you needed to, which is why we've put it on the quick referrals template and asked them to add it into Ardens for you.
Great, thanks. And then there's a question here: does the GP practice have to activate the computer system for the pop-up for it to appear automatically?
No, when I make it live, it'll just happen for everybody across Dorset. In the GP practices, I should say, just to make it abundantly clear.
Questions for Lee? No, that was really helpful. Thanks, Lee. It's really useful now to know where to look.
That's fine. I said I can always help you out with screenshots to put into the guidance that you're sending out as well, and the comms you're sending out. So if you need more screenshots, just give me a shout and we can generate those for you.
Great. Thank you. Real. So yeah, thanks, Lee. So just in the interest of time, we'll go through these fairly quickly because we'll share this information, but here are some tips as well if you're not too used to using the searches. The main thing to be aware of with this program, as you've heard, it's quite an intense program. There's going to be quite a big commitment from the patient, is that the search may produce eligible patients, but it's that second check of are they actually suitable for a program like this, and will they cope on a program such as this. So this is just some information for you on that. So this is a resource that we will have on our website, which will be part of the follow-up email we will share, which contains lots of helpful information, including screenshots that Lee has already told you about. The links at the top are all interactive as well, including the referral support session. So if you would like to book in a time with one of our team, please use that link and we're happy to come along and join. It's a bit of a recap of everything we've discussed, so it's a really good resource to use to reflect back on. It covers the first part, which is how to identify patients, so the search, invitation, or the usual care, both of which we ask that you do to speak to the patient about the programme and make sure that they do actually know about the programme information and make an informed decision before starting the process. Once they are happy to have a referral, again, just allowing that time around 15 minutes to make sure the patient does know about the changes that they may be making in terms of their medications and to send these in writing. Patients may not start on the programme, patient choice in terms of how long they start, so it's really important they do leave the appointment and know what changes you've requested with them. And the main thing around medication changes as well is that it's on the first day of total diet replacement and not the first day that they leave their appointment with yourselves. Once they come to our team in Momenta, we will check the eligibility again. We will confirm that they've got all the information that we need to process the referral. And we will also check medications, and any of the ones that Ollie went through that are not safe have all been marked as to be stopped. Patients will then be given the choice of the two delivery models, so the in-person one-to-one or digital one-to-one, and they'll be able to make a decision with our onboarding team. We'll also support with filling in any knowledge gaps that the patient may have about the programme. Once they're on the programme, we then provide all the equipment and products that they need. And again, there's no cost to the patient for this. There are certain times we'll contact yourselves. So if a patient is to be discharged due to being ineligible, whether they've declined, dropped out or completed, if anyone does have any threshold breaches, again, we will let you know in the same way as we would if we have any kind of missing information. And finally, that the HbA1c, as a reminder, does stay with the GP practice. And if there are any ongoing medication reviews, again, this will all stay with the practice. So usual care remains the same for the patients on this programme. So next steps, here are some contact details from a few of the speakers today. So from a Momenta point of view, you've got my email, which will be shared very soon after this meeting or by tomorrow, definitely. And Harry, our director. We do have Dr. Ellen Fellows, who's our supported in the background, as well as our medical director. So if you do need some extra information or advice or support, please do let us know. From a Dorset point of view, we have Sharon and Ollie as well. Again, their emails are all there for you. Great, so we have some time now to go through any questions and we'll kind of check over the chat as well. Our referral website is going to be the main place where you can get all the information. So we'll share that with all the training video will be on there, the slides, a few of the resources, as well as where to send patients if patients also would like to look. And as mentioned, we are really keen, especially this program is just launching, to support practices and PCNs. So if you would like us to join one of your meetings, please do let us know. If you email me, we'll happily book that in. We're also going to be delivering this programme all across Dorset. So if your practice is interested in hosting this service, please again let us know. We do find success in offering both community settings and offering some sessions within the practice directly as well. And that's everything from us. Sorry, I was just going to say thank you. Yeah, we look forward to your referrals. You've got the emails for the inboxes, which are managed by myself and some of the wider teams. So if you have questions about particular patients, please do just let us know by email before you refer if actually you're not too sure about the patient's suitability.
Thank you, Becky. I think just to pick up on some of the comments in the chat before the time completely runs out. Becky covered, I think, the question about being face-to-face or in person. It's the patient choice of either, but once they've made that choice and started the program, they have to stick with the choice that they've made. But we'll make that clear to them before they make that, obviously. In terms of the venues, we've got a short, kind of long list of community venues, and But as Becky said, we'd also be very happy to deliver the service in GP practices that are keen to have it delivered in practice, because it's a one-to-one clinic. That's much more feasible in many practices than group programs like the DPPR, where often there's space constraints. But we can work with you if you think you'd like to put on, like us to put on a clinic for your patients, and you refer a number at the same time, then we'll be very happy to do that. So in terms of locations, the exact locations are slightly unclear because we have to wait until we hear where people that you refer to us, which ones want it in person, and then we will look at putting on a clinic in a convenient location for those people. So it's a little bit reactive. If you have any suggestions, please feel free to send them to us. Your question about if people drop out, can they be re-referred? Yes, they can be re-referred immediately if they haven't started the service. If they've actually started the service, then they can only be re-referred after 12 months from their discharge date. So if they start and are discharged 12 months after that, they can be anyone can be re-referred, but not in between once they've started. Same is true if they regain weight after a few years. Checks are in place. So to identify patients with eating disorders who should not be put on this pathway, obviously that's one of the exclusion criteria, but we know that eating disorders aren't always identified up front. So we don't have a specific eating disorder screening questionnaire that's validated, because that's not part of our role in the NHS and specification. But we train our advisors and our coaches to look out for signs of that. And we also have a readiness questionnaire, which helps people think about whether this kind of total diet replacement could trigger unhealthy attitudes to or approaches to foods, especially because they know themselves best and from their past experiences. So even if they haven't been technically diagnosed, we try to help them think about it and see if they would find it problematic. And also, as I mentioned, our dietitian is quite she's obviously extremely clued up on eating disorders, but is and specializes in this area, so is good at being aware of the kind of warning signs of that. The onus, though, ideally is not to refer people with eating disorders in the first place. Another question about exit pathway. So the first point is it's a path to remission, so it's not just about achieving remission. And in fact, depending on the medications people are on, if they have to remain on a first-line agent, they can't achieve remission as it's defined in this service, because they'll still be on one medication at least. But they can still get many of the other benefits. So we try to set it up for your patients that they don't see not achieving remission as failure. And that's the first most important point. The second point is that we help them look at maximizing their chances of achieving remission, but not having that as the only focus, and also keeping it, being very aware of the other benefits they can get from significant weight loss. And then in terms of exit pathways, we obviously signpost to relevant national initiatives, but are also increasingly populating our kind of signposting for local initiatives as well that could support with ongoing management or other relevant services. Again, if you have services, we've obviously started to gather those. If you have services, please make us aware of those. Just looking at the chat, I think that's most of it. There's a specific question, Becky, about venue in Purbeck. I think that depends slightly on, that's from Lydia, depends slightly on the